Conference will now be recorded. This conference will
This
now be
conference will
recorded.
now be
Put
recorded.
out there for everybody, but it's just kind of something that's since you're already here, like think about it. Because I'm gonna be real honest with you, this is how this is about to go. If everybody in this class right now says I want to take that EMT class, a third of y'all will probably get to take it because we're limiting because it's our first EMT class. We also have the last EMT class that we did, as well as some internal employees that want to do it. So between the internal employees, the last EMT class, this EMT class, it's going to fill up really fast because we're probably going to limit this one to probably 12 people. And it's going to be
We're
like
most likely gonna do like interviews, so it's gonna be like a selective process.
it is going to be, it's not going to be like the EMT class where we let everybody in. It is going to be a process where if we don't feel like you're going to be dedicated to this because it is a hard class to get through and pass that test, if we don't feel like there's going to be dedication, then we're going to be selective. It's going to be like a job interview where we bring people in, we sit them down, we talk to them, see where their head is, and then we pick a group of people that we feel like kind of work out best for the class.
I'll wait until the next one. I at least want to get a year again under before I do anything.
Yeah, well, like I always recommend, this is me personally, like I got my EMT in 2015, then I got my AEMT in 2016.
Yeah.
But then I waited until 2020, whatever, to get my paramedic. So like your EMT and AEMT, I wouldn't be like, wait however long to get your AEMT because there's a lot of the same stuff. You're just doing a little bit more invasive skills. There's some states like Idaho where I came from, I could get advanced modules, so I didn't have to be an AEMT and I could still do IVs, IOs, and supraglottic airways. And that's more helpful, to everybody that's working. So I'm not as stringent on like, okay, wait to get your AEMT, but if you want to go to paramedic, yes,
You need to wait at
wait
least
those
3
3 years, yeah.
Yeah, at least 3 years. And it really depends on where you're at and how busy you are. Because like even working in Atlanta, we pulled the numbers one time, and me and Becca were seeing like around 2,500 patients a year, and that was just me and Becca. And so we were seeing over 2,000 people in the back of an ambulance a year.
How many of them were the same?
About 2,000. So, no, but, and so you think about that, right? So Lander County EMS last year ran just under 1,100 calls. So in the entirety of Lander County, we ran just under 1,100 calls. And me and Becca were seeing almost triple that by ourselves in the city of Atlanta in 1 year. So when you think about, we ran 1,100 calls here, we have 3 separate shifts. So if you break that down, each crew was seeing like 350 patients a year last year. And that's just if you break it down statistically, right? I ran probably more calls than anybody did last year because that's just how my shifts go, right? But, yeah, and that's just how it goes, right? Where I saw more patients than almost anybody, like Jenny and Hoover shift don't see as many patients, right? So like, it depends, right? So those are two different, around here, it's not like a vast number difference. But when you're talking about me and Becca seeing almost 3,000 patients a year versus 300 patients a year, that's a huge difference, right? And so that's where we say, like, especially being out here, you need a few years before you go to paramedic school. Like, you need time. Like, Marcus has been an EMT. By the time he finishes paramedic school, he'll have almost 4 years as an EMT, right? So, like, that's where we encourage people, like, because once you get your paramedic license, depending on where you go, like, you're it. You're not lucky like you are in Lander County, where we have 5 paramedics on staff and 1 EMT. And that 1 EMT is about to be a paramedic, right? So we're potentially looking at 6 paramedics on staff. So our entire full-time staff is going to be paramedics, right? Well, not everywhere does that. You go to Humboldt County or you go to Elko County, you got an EMT and a paramedic. Well, if you're in Elko County or Humboldt County and you go up there to that reservation on the Oregon line and it's you and your little EMT partner, you're it, tag, for the next hour or however long it takes you to get somewhere else. So that's where the experience of like time comes in. So that's where we encourage people, like, you need time before you go to paramedic school, because you are making the decisions. People's lives depend on you making the right decisions. Being an EMT is very nice, and honestly, most of the time I wish I could go back to doing it.
And every good paramedic has been a great EMT.
Like, you have to be really good at being an EMT, because if you don't know how to assess a patient, these 4 chapters that we're going over are by far the most critical points of what you're doing. Because if you don't know how to talk to patients, if you don't know how to assess patients, if you don't know how to walk in there and look at a patient, like I like to say, I have about a 30-second window from the time I walk in the house to say whether I need to leave or whether I have time to sit there and play for a minute, right? Billy's ridden with us 1,000 times, and he can tell you that when we walk inside of a house, 1 or 2 things are about to happen. I'm about to let Billy pull out the monitor and like start doing vitals, or I'm going to tell Billy to go get the stretcher, we're leaving, right? You have to be real good at what you do as an EMT to make it to be a good paramedic, because you can pass paramedic school. We had a young lady come through here last year that went through EMT, advanced EMT, and straight into paramedic school, never seen the back of an ambulance outside of her clinicals. She was one of the smartest people that you would probably ever encounter. Didn't have a goddamn clue what she was doing in the back of an ambulance. And I say that as nice as I can, because she just didn't have the experience. Lucky for us, we told her, we were like, hey, listen, you really need to go to a city and get your butt kicked for the next 2 years. Like, you do not need to work in a community like this, because we are paramedics that are working for hours by ourselves, very, very aggressively. Like, you have to be good to be out here. You need to go to a city where you're like 10, 15 minutes from 5 hospitals and just absolutely get your teeth kicked in for the next 2 years. And now she works out of Vegas. And she said it was probably one of the best decisions that she's ever made. Same thing with Hannah McCaffrey. Hannah was an absolutely wonderful person, super intelligent. And she would flat out tell you now that she's working in Charlotte, North Carolina, getting her teeth kicked in every day, that she didn't have a freaking clue what she was doing out here, because she had never been anywhere but here working on an ambulance, and she just didn't have the experience. And now that she works in Charlotte, she texts me, or she texts back all the time. She's like, I feel so stupid because I see so many people and I don't feel like I know what I'm doing. So time and experience is your best friend in this, but work really hard at getting good at this, and you can be a really good paramedic. But these assessments are really what makes a good EMT. So, sorry, that was good.
So, here you go.
How long is the actual paramedic?
Yes. The paramedic course, it depends on where you go. So the one he did was 9 months. The one I did was,
Oh, 11.
11, I'm sorry. And mine was 17
I do
months.
not recommend an 11-month paramedic
It's like really drinking through fire hose, yeah. The one at GBC is 2 years,
I think it's 18 months.
18 months. It's long.
Yeah, it's pretty, which is a good time. Like 18 months is pretty good. Like, it's not excessive, but it's not like drinking through a fire hose. 11 months is rough. 18 months is a good like happy medium. Like freaking Ursula went through paramedic school, and she was in paramedic school for like 2.5 years.
Which is crazy.
So.
All right, assessments. More assessment stuff. All right, so I put chapters 15 and 16 in one PowerPoint. We're going to get through it. We're going to practice vitals. So if we get through it in time, we kind of clucked a little bit.
Sorry.
All right. All right, so we're going to review the points in our secondary assessment. We're going to identify when to reassess specific patients, which we already know, right? Stable, unstable. Talked about that. And then we're going to learn acronyms for assessing patients. We already learned most of them. DCAT BTLS. Who can say it right now?
DCAT BTLS.
Good job. All right, so the paper that we all are becoming so familiar with, this is the section that we're talking about. So this is the medical one. if you have your trauma one and you pull it out, you don't have to, but if you have it with you, you will see that it is a little bit different on the history taking part. But most of our trauma patients, we don't have, I say most of them, not really. If they're like unconscious or something, trauma is usually those people, so you don't get that like secondary assessment of like OPQRST, sample, what's your past medical history, you know, it's hard to get all of that, but, so here you are, medical history taking, secondary assessment. All right, so we have 3 categories. We have our medical patient, which would be your medical sheet, your trauma patient, which would be your trauma sheet, and then your unknown patient. So sometimes things happen, you get called out, and you don't really know, like they're on the ground. Did they fall and become unconscious, or were they unconscious and they fell? Did something medical cause them to fall? Did something medical cause them to wreck their car? Sometimes you have medical and trauma patient. Perfect example of this, we go out, get called out to somebody that wrecked into a tree, and like by the looks of their car, it doesn't look that bad. Like, okay, they shouldn't be unconscious, but they're dead in the front seat. Come to find out, they had a giant pulmonary embolism. They died while they were driving, hit the tree. So sometimes it's hard to pinpoint exactly what kind of call it is. All right, so 3 basic components. We have our physical exam, our patient history, and then our vital signs. So physical exam is hands on the patient. You're asking the questions. We're talking about each one of those systems. I'm going to run you guys through. I'll bring Hal in here, our little mannequin, or I'll have Billy come up here, and I'll do a quick rapid assessment so you guys can see what that should look like in our trauma assessment. All right. So when we talk about signs and symptoms, right, you'll hear a lot of that. Signs and symptoms, signs and symptoms. Sign is what you can see, and then symptom is what the patient tells you. So if I'm puking and you see me vomiting, is that a sign or a symptom?
It's a sign.
It's a sign. Now if I say my belly hurts really bad,
That's
your symptom, right? All right. So we know what HPI means. We learned that our last PowerPoint, history of present illness. So what history does the patient have that relates to the chief complaint? Whereas if somebody was to say I have shortness of breath, okay, I have a history of COPD, that would relate to shortness of breath. We're asking open-ended questions. This should all be reviewed from last Tuesday, right? What does SAMPLE stand for?
signs and symptoms, allergies, medicine, pertinent medical history,
Ins and outs.
last sentence out, and then events leading up to us.
Very good. Very good. All right, we're obtaining baseline sets of vitals on every patient, right? How many sets of vitals do we want to try and get? Good. 3 for every transport, right? If you're staying on scene for whatever reason, gonna catch a refusal, that's dependent on the patient. But every time we transport somebody, you should have at least 3 sets. It's kind of hard out here sometimes because we get called right there. That's in like an independent living facility over there. And so we get called out there a couple times. So getting 3 sets of vitals from there to there, we'll still try and get 3 sets, right?
Yeah, something.
Bravo, like, blood pressure, lizard. All right, so blood pressure, SpO2, temperature, pulse rate, respirations, and SpO2. Oh, SpO2 is up there, even though it's not a vital sign. That still chaps my butt. And then BGL if indicated, so blood glucose if it's indicated. I'm kind of a stickler about that. I'll do blood sugars if it's indicated. I won't just do them on everybody. Some agencies that you work for will charge like individually for each blood sugar obtained, which I feel is ridiculous because you can buy a blood glucose machine and each one of those strips is probably like 5 cents. And some places charge like $60 just for us to check their blood sugar, which I feel is ridiculous. But do you? Grady was like that too. I'm like, why? They stubbed their toe. All right, so reassessment.
Well,
Sorry, someone say goodbye. Okay, sorry. All right. I'm deaf, so y'all gotta yell at me. All right, so our reassessment, it's a continual thing, right? They like to put numbers on it, we say every 5 minutes. In your really critical patients, you should be continuously assessing them. You're trying to do interventions, and then you're gonna keep monitoring for your interventions. So it's not like I'm gonna do something and then 5 minutes later, look at my patient again. This is like a continual process. So every 5 minutes for an unstable patient, every 15 for a stable patient. If they have the potential to become unstable, I'm still going to do 5 minutes. And then every 10 minutes for a trauma patient. So trauma patients kind of are pretty good at hiding underlying illnesses or injuries that may be going on, more injuries. So I assess them every 10 minutes. Pretty sure it says that in your book too. It was drilled in my head all through EMT school. So we're going to do it. All right, so if someone's responsive, obviously they can answer your questions most of the time, right? If you can't talk to the patient for whatever reason, if they're unresponsive or they're out of it, say it's like a bad dementia case, try and ask like the family members, the caretakers, anybody that might be around. Sometimes, like if a neighbor walks over and they're like, hey, how's Miss Betty doing? And that person knows a lot, I'll try and get some information from them too. It's whoever's on scene that can answer questions. Look for pill bottles. This is kind of one of those skills that come a little bit later after running a few calls. Like you'll notice your first few calls, everything's just gonna be tunnel vision. Like patient, crap. And then as soon as you start running more and more, you'll learn to start looking around the scene and being like, oh, there's some pill bottles here, or there's a nebulizer set up over here. Whatever it may be.
If there are pill bottles or something like that present, you take them with the patient, you leave them there, like, don't know what they are.
So if they have like a bag of their medicine, a lot of times I'll try to just write them down. Because if you're like bringing all of their medicine with them to the hospital, a lot of times it can get lost. And so I don't want to be responsible for any of that. So I'll take pictures of them like on the duty phone, or I'll write them down. Unless they're like persistent on me taking their meds with them. If I don't have time to sit there and take pictures of all of them and write them down, I'll just grab the whole bag and take it with me. Also take note if you're dealing with like any kind of overdose or any kind of weird symptoms that could relate to any medication that they're taking. Take note of how many pills are in the bottle. It says on these bottles how many pills are in there, how often they should be taking them. And so if they have a 30-day refill and they only have 2 days left and they just got it filled yesterday, that's a pretty good sign that maybe they took too much. That's not always on purpose, right? Sometimes they're just like, oh, this is aspirin, I'm going to take this much, and it's actually their beta blocker. So make sure you're looking at that pretty close. Same thing with like even over-the-counter medication. So yeah.
sorry, what's a beta blocker?
It's a blood pressure pill, or it's a heart rate control. It depends on what they're given for, but it can slow your heart rate down. So beta blocker are beta receptors, which we learned about. Yeah. Yeah, let me kind of go over this with them. Dad reminded me of this the other day. I'm trying to write it here so Tina can see it. Golly. That's really delayed. Okay, so we have alpha receptors and we have beta receptors. So remember what each one does. A, B, C, D. So alpha constricts, beta dilates. You have 2 types of beta receptors. You have beta 1 because you have 1 heart. You have beta 2, you have 2 lungs. The beta 2 lives in your lungs. When we start talking about albuterol, right, it's a beta 2 agonist, yeah? So since it's a beta 2, it dilates, because beta dilates. And where does it dilate? Lungs, very good. Thank you for reminding me of that. I know that's kind of not my subject. Can y'all see that over there?
Thank you.
Yeah. Okay, very good. All right, so our systems. Whenever you look on your pages, it goes through all the systems. So anytime you have a medical patient, we try to assess at least 5 symptoms. Like I said, even if it's super obvious that it's one system, we always want to check other ones just to kind of cover our butt, maybe catch something that we would have missed. Sometimes we get that tunnel vision of like, this is what's wrong with the patient, and we don't look at anything else. So all of our systems, we have cardiovascular. How would you assess a cardiovascular system?
The pulse.
Pulse, good. Can you guys do a 12 lead?
Not yet.
We can hook one up.
You
but we
can
can't
hook one
read it.
up. Yeah, absolutely. So if you have it in your protocol to obtain your 12 lead, you can absolutely do that. There's a lot of places that have telehealth, so you can hook up the 12 lead, send the 12 lead off to somebody to read, and then they'll get back a hold of you and say, do this, do that. This looks like shit. So you can obtain a 12 lead. You just can't read it.
Have we gone over the placement for a 12 lead?
Not yet. We will though. Y'all will be very familiar, especially on your rides. So when you ride with me, you're putting on 12 leads. I do 12 leads on almost everybody. So pulmonary. So what's our pulmonary system? Lungs, right? How do we assess pulmonary?
Auscultation.
Lung sounds, yeah, auscultation. What else?
SpO2.
Respiratory rate, SpO2. So that's a good way to look at pulmonary. Neurological, what's that?
Checking their mom's mental status.
Yeah, stroke test, brain, any kind of deficits, right? So do they have that fast scale? Do they walk funny? Those are things that we look at for neurological.
What was that called? Whatever they walk funny?
Ataxic.
Taxi.
Ataxic gait. Really close. It was yeah, ataxic gait. All right, musculoskeletal. What is that? Bones.
Bones and
Mhm.
muscles.
Yeah,
When you do
bones
an
and muscles,
offset.
right? So this can kind of play into cardiovascular, right? Because if someone has chest pain, then it's a muscle problem. And we assess musculoskeletal on the chest. That's 2 systems being assessed right there. So that's why it's important to kind of look at everything, right? What is that?
Skin.
Good. How do we assess that?
Color.
Yeah, color, temperature, and condition. Right, so we're gonna feel it, we're gonna look at it. What's that?
Gastrointestinal.
Yeah, the guts. I will say that GI is like one of the more difficult things to kind of pinpoint what's wrong with the patient. Unless it's super obvious, like your appendix, like that's a very obvious presentation. But if they kind of just have like generalized abdominal stuff going on, it's really hard to pinpoint. Like, oh yeah, it's your gallbladder or it's your pancreas, you know?
So the gal who was sitting in like in a puddle of her own feces, that would be gastrointestinal theory, like as a possibility.
It could be, yeah. So like one of my differentials for her, like differential diagnosis was C. diff. She was like really weak. Her blood pressure was low. So we talked about C. diff. It makes you have diarrhea. And she was sitting in a lot of diarrhea. So, yeah.
You go on one of those calls, you start like gagging or something. Is that like down upon you walk out, or
Don't
you just,
puke directly on the patient. Try
or
to make
you
it
can like,
attractive.
yeah, and then start.
I keep emesis bags like on the stretcher for that reason. I've had a couple partners actually start vomiting, trying to make it out of the house.
No, no people.
For what?
Heights.
Height?
0 chance.
You don't like heights?
Hell no.
Oh no. We're like, we need you to climb up there.
I'd be like, you're.
You're like, anyways, I'm going home. That's funny.
The guy you want to come rescue on ropes is this guy. He'll just grab you, hold you, and still go down.
probably like pinky. It's like, come here.
He's on his kid in his legs. I was like, how do you feel, Dory? He's like, not like a man. What do we got, man?
That's funny. So a good question for GI too is that last ins and outs question. That's a good gastrointestinal assessment, right? Palpate the belly. If someone's hurting left lower quadrant, where do I start palpating?
Right, upper.
Upper right, good, yeah. Furthest point from it and work your way to it. Good. Y'all are so smart. Reproductive. What is that?
The fist check.
Do not do the fist. If I see one of y'all do that, I'm going home. You'll be like, hold on. You're like, see y'all later. I'm done. I quit. So for this one, obviously, unless like somebody's comfortable, if they're like, yeah, I'm having a lot of bleeding, you don't have to like visually assess the reproductive system, right? I will say if you have a female that has any indication that she's in labor and she looks like she's to term, you do need to check for crowning. As uncomfortable as it is, there's been plenty of stories where they're walking the patient in or they're wheeling the patient in and they're like actively having the baby because someone was too like, I don't want to look. So always look. But like sexual assault, something like that, don't be like, I need to assess you. That's not up to you. Unless they're like, hey, look at me. Okay, whatever. But you can ask when their last period was. That's a big one for like any kind of trauma. You always want to figure out if there's a possibility that they're pregnant. So figuring that out. Any kind of abdominal pain, same kind of thing in females or males, or what looks like males. We've had a couple patients that you're like, what? So ask them when their last period was. That's a big one because any kind of abdominal pain, we'll go into this in more detail, but any abdominal pain in a woman of childbearing age is an ectopic pregnancy until proven otherwise. So you need to treat it as such. So it's always important to ask, like, when was your last period, for those kinds of things. All right, psychological, don't go palpating their head. That'd be a musculoskeletal thing. What can we ask for like psychological or social?
The day and the time, stuff like that.
Good, yeah, figure out their mental status, right? What about like depression? We get called to suicidal subjects a lot. What are some other things you might want to assess?
If there's like abuse if it's a kid or
Good.
something.
What else?
Look around the scene and see what the scene looks like too.
Yeah.
How are you feeling?
Yeah.
Why are you feeling like this?
Yeah.
Just talk to them.
Yeah, if you have a suicidal patient, ask them like if they have a plan, right? I know that seems really straightforward, but those are important questions because once we get them to the ER, and if they talk about putting them on a legal 2K and L2K or like a legal hold, they'll ask those questions anyway. So if you can kind of talk to the patient about it before, that can be helpful for wherever they're going. Another thing I wanted to say, like you said, like look around their house. What are they living in? I stand by that people's mental state is reflected as to like how their living situation looks. So like severe depression. Hi, welcome back.
Sorry, there was a nurse starting IV for like one of the first times, so I'm awkwardly stood over top of it, made her feel uncomfortable about it.
Oh, good. It's the rite of passage. Everybody's been through that, yeah. If you're dealing with any kind of like psychological thing, also ask about hallucinations. That's a big one. So are you having any visual or auditory hallucinations? I always ask, like, are you seeing something I don't see or hearing anything I don't hear? Because if someone's having like a psychotic break or like a manic episode, schizophrenic episode, there'll be other signs that'll kind of prompt you to ask those questions. But it's important to ask those things because sometimes those little voices tell them to hurt you. And it's kind of important to know that. So, yeah.
Means you're going rounds.
Yes. Yeah, I've had somebody say to me before, like, please, like, tie me down because the voices are telling me to hurt you and I don't want to hurt you. And I'm like, you got it. Like, you got it. Yes, sir. All right. So chief complaint. What is a chief complaint?
Reason you're there.
Why we were called.
Yeah. What's the patient's reason as to why you were called? Again, this might not match like exactly what's going on with the patient. But that is the chief complaint. So ask questions pertinent to the chief complaint. What do you think that might kind of talk about there? What does that mean?
Ask about what their original reason for calling was.
Good.
Instead of something else, like if you walk up and there's something else is going on,
Mhm.
because you're just asking about the first one first.
Yeah. So ask them pertinent questions. Now, if I walk in and they're like, I really stubbed my toe and they have a gunshot to their chest, we might change things, right? But whenever we're like asking those questions specifically, how can these things relate? What are we seeing and how does it relate to what they're complaining about, right? All right, chest pain. Do you have a history of heart problems? What medication do you take for your heart? Again, this is all review. Same stuff we were talking about last Tuesday, Thursday, whatever day we were here. Tuesday. What's OPQR?
OPQR, radiation, S severity.
Very good, very good. The cup of doom. Marissa, I'm your patient. How do you ask me about onset? Marissa, you took the same, almost the same name.
Oh, I was like, wait, I know it's me.
I didn't know it was you. You're gonna think you're looking at
Makes me laugh.
what is
I
onset?
would ask you when it started.
Good.
What they're doing, when it started off in sample.
All right, Jessica. What is P?
So provocation, so you're gonna ask what brought it on?
Not
Better
that
word.
word. Not quite. That's kind of more of like your like sample questions, like events leading up to. So provocation. Does anyone want to assist? Yeah, what makes it better or worse? So what provokes it? Okay, very good. Jake.
Quality.
Q.
On a scale of 1 to 10, how bad is
That's severity.
it? Severity. So,
Anybody else?
Description of it.
Description of it.
Yeah, like, is it sharp? Well, it's gotta be open. It's gotta be open-ended, right?
Yeah.
Can you
Describe what it feels like.
Yeah. Billy, what are we on? R? Yeah, we're sorry.
Does your pain go anywhere else other than where it's
Good, good. Mariana, there we go.
Severity, so like they scale of 1 to 10.
Good, good. All right, so lucky last. It's like going through it right now. She's driving down. Lakin.
So like how long has it been going on?
Yeah, it can, so time is kind of that weird one, right? So you can ask like, how long has this been going on? How long have you been dealing with this? Or have you ever dealt with this before? Because onset and time, like in my head, are like the same thing, right? But they're a little bit different, whereas time is like, have you had this problem before? If so, how long? Does that make sense? Huh? Yeah, they're kind of confusing.
Why is the P lowercase?
I don't.
What?
Where? Oh. The O and the P is, yeah, don't worry about it. Don't worry. Listen, I was typing, you know? All right, physical exam. This can be brief. This can be beef. The cows. So you're going to examine their areas of concern, right? So wherever their chief complaint is. If they have chest pain, I'm going to examine their chest. I'm going to look at their chest. I'm going to listen. I'm going to feel, right? Look, listen, feel. That's the big thing about a physical exam.
For dudes, like on chick, whatever, she's putting out chest pain,
Mhm.
you're like having to palpate or whatever, you like, whatever we were talking about in here, the lady said you back to your hand, so it's.
I'm gonna be the one to say this, because Becca's gonna give you the technical answer. We assess, don't caress.
Yeah.
Assess.
Listen, I've never had a person get mad at me for assessing their body. Like, and, you know, we're in a professional environment, right? Like, I'm not gonna walk in there and be like, when you're assessing your patient, like, if you're using like your fingertips, because I use my fingertips. Like, even if I'm like palpating for like ribs and stuff, I'll go in and like just use my fingertips to like touch around. I'm not saying that they're not gonna get mad. I've just never had somebody, and maybe it's just because I don't talk to people. I don't know. They've never got mad at me.
So the back of the hand thing to me, if I need to move a tibia out of the way because I'm putting on a 12 lead or I'm looking at something, I'm gonna use the back of my hand. But if I'm palpating someone's chest, I'm gonna use like, hey, I'm gonna feel your chest. Is that okay? If they're like, no, okay, that's on you.
Just tell them what you're doing.
But you tell them what you're doing, assess, you're gonna feel things better if you, especially like if someone had broken ribs or something weird like crepitus or something. And as I feel, like you're gonna feel it better this way and going like this, right? You can pinpoint where it's at.
Yeah, I just don't wanna get like a target on or something.
Yeah.
I'll be honest with you, a lot of times, this might sound weird, especially for like the more robust groups. I've taken like shirts and just grab their shirt and pull things out of the way.
You're not necessarily touching, so you're.
Yeah, exactly, right? I put my first two leads on and then I just grab like a shirt and I just grab the whole shirt and I move things out of the way. I mean, you think about, like, I don't know if you've ever been to the city of Atlanta, but people there eat like some very protein-rich chicken, I guess. I don't know, but those things are scary sometimes. You know, like a whole like floor jack thing. It's very aggressive.
Yeah. I was just gonna say something else, but I lost it because you said that.
But you know what I'm talking about.
I do.
Do you consider that refusal of care, like for that treatment? So then you would make note of that in your report. If
Yeah.
they're like,
Yeah.
no,
Yeah.
don't touch me.
Yeah, if it's like they're complaining something specifically of their chest, I'm like super concerned about it. Now, if I'm just kind of doing an assessment and they're like, don't touch me, that's one thing. But if they like got beat in the chest with a baseball bat and they won't let me assess them, then I'm gonna document it. It's kind of case dependent, right?
Like
And
if, you know, they twisted their ankle and, you know, fail. And the only thing they care about is their ankle, and you're like, well, I need to assess like your chest. And they're like, no. Like, do you really need to like palpate their chest? Like, really not, but, you know,
Yeah.
like I said, if they just got freaking shot in the chest and they're like, don't touch my chest. Well, that's a different conversation.
Sorry, we got such a chance.
yeah, and for something like that, even like certain medication refusals, assessment refusals, I will have them sign a refusal form. Even though I'm transporting them, I'll write on the refusal form like refuse this med or refuse this assessment. Yeah, it's not very often that you run into that, but it is important to document it. And then anytime somebody refuses something, they always have a right to refuse, but they also have a right to know what they're what's gonna happen or could happen.
So is that more of a CYA on your part?
Yes.
And explaining it to them, right? Say, listen, you called because your chest hurts. I need to do this 12 lead. If I don't do this 12 lead, like there could be things that we're missing, like potential heart attacks or dysrhythmias. If I don't do this, just understand that there could be potentially life-threatening things going on with you that I can't see. If they're like, Ricky, you're not doing it, cool, you mind signing this for me? And then document it in your report, you know, 12 lead was attempted, you know, patient refused, patient was explained risk of refusing, patient acknowledged it, still refused, right? Like something like that.
Yeah. So you still run through your refusal spiel, but it's just for a different reason, like not refusal of transport. Yeah. So. Oh, I remember what I was gonna say now. Now we were talking about like using your fingertips to assess somebody. The only caveat to that is if you're assessing a skull, use the flat part of your fingers. Don't go digging your grubby little fingers in skull fractures. If you go like this and they have a depressed skull fracture, now you're pushing it in more, don't do that. Just kind of like palpate like this. That's the only caveat. Don't be, unless you're like Hoover, you stick your whole finger in someone's brain.
Who, what?
He was,
They actually teach you in like TECC to like do like the right thing, like under fire. And so if you're looking for gunshots, you like rake your finger down people and they'll find gunshot holes. So it's not gonna hurt, but it's a monotony. Unless you just wanna freaking tickle their medulla oblongata.
yeah.
You see what distance.
All right, so
You like touch a part of their head and they're like, wham. Oh, God.
yeah. All right, so remember, a decision for prompt transportation is part of your treatment plan. So your treatment plan includes getting them to the hospital real fast because it's a time-sensitive emergency. That is part of your treatment plan. Yeah. All right, kids, talk about this a little bit. So get on the kids' level. Don't go walking, hey, kiddo, like kind of work up to it, right? Put questions in simple language. Kids, everybody here has been around kids at some point in their life, I'm sure. So put questions in simple language, and then any kind of information from mom, dad, caregivers, aunts, uncles, family, whoever. Again, if they have like some weird medical history, those parents most likely are going to be well versed in that complaint and whatever is going on with them.
Yeah, we had one recently that had like special medical equipment that was in town that I have never dealt with. And I put mom in the back of the truck and was like, what buttons do I touch? And do I not touch? Like, don't be afraid to be that person. If you don't know, it's better to ask than it is to start touching stuff and cause harm.
So, unresponsive medical patient. This is the secondary assessment. Our primary assessment starts with what in the unresponsive? Right? Checking for a pulse first. CAB, right? This is our secondary assessment. So we've moved down the sheet. We've made sure the airway's good. They're breathing, their circulation, right? Now we're doing a secondary assessment. The physical exam, if someone's completely unresponsive, you can try and get some information from whoever's around. But you still need to do a rapid assessment of the entire body. And that is exposing them. That's looking at them, doing a quick like sweep. We're looking for any major bleeding. That should have been done in your primary. But other things might clue you in, right? If you have an unresponsive patient and they're all bundled up and wearing 10 sweaters, you start peeling those off and you see an insulin pump or something weird, right? It can kind of clue you in as to why they're unresponsive. So, head to toe, rapid physical exam. This is quick, right? You have all the ABCs figured out. Their breathing's good, their airway's fixed, their circulation is assessed. They're being treated for shock. You're past your primary assessment. You move on to your secondary assessment. So, head to toe, we're going to look at our pupils, right? What do we want our pupils to be?
Equal, reactive, round, and accommodating.
Accommodating. Good. And then any kind of drainage. So especially trauma patients, we're looking for drainage out of ears or nose. Any other kind of drainage, if someone has drainage out of their mouth, if it's blood, if it's vomit, we're going to be looking for all that. That, if it's in the airway, it should have been assessed during your ABCs. But right now is another time to look for it. What's JVD?
Distended jugular vein.
Does anybody remember what it can be a sign of?
Pneumothorax.
Pneumothorax.
CHF.
CHF.
What was CHF?
Yeah.
Congestive heart failure.
Oh, also the blocked artery, wasn't it?
Not
Or was it a
so much, but like a pleural effusion, not pleural effusion, I'm sorry, cardiac effusion. So like a pericardial tamponade, pericardial effusion, any kind of fluid building up around that sac of the heart because it's pushing everything back up. Around the neck, sometimes people wear little necklaces with their IDs, so that you can look for that. Chest, we're looking for breath sounds. We're looking at the chest. We're checking if it's a trauma patient, we're going to palpate. The abdomen, we're going to palpate the abdomen. We're going to check for distension. What is that?
It's not showing the swelling.
It's like internal bleeding usually.
Yeah, it's like bloating, basically swelling in the belly. Firmness, if you feel like a firm mass, if you feel a pulsating mass, if it's like rigid, even if someone's unresponsive and you're palpating their belly and they do like this with their face, sometimes they'll grimace. So like as you're palpating, kind of look up at their face, because sometimes they'll grimace at you, even though they're unresponsive. So that's one thing to look for. What is incontinence?
Can't hold their bowels and urine.
Yeah, so if they're incontinent, if they pooed or peed themselves, that is incontinence. So a lot of times, like seizure patients, they will lose like their bladder, right? So if someone's unconscious, unresponsive, or like super altered and they peed themselves, like that can be a sign to you, like, hey, maybe they had a seizure, right? And then what does CMS stand for? Sometimes you'll hear
No.
PMS. So it's you said cap.
I
No,
was
like
thinking
capillary.
cap refill was
It's
like,
circulation, motor, and sensory. We're gonna check that in all of the extremities. So you check for a pulse, that's your circulation. If they can talk to you, you're gonna say, hey, move your fingers for me. And then sensory, you can say, hey, can you feel me touching your hands? Or you can sit there and pinch them or scratch them and say, am I pinching or scratching? So you want to make sure that they can feel everything, that they can move, and that they still have a pulse. So you will become intimately familiar with CMS because every trauma patient gets a CMS assessment. Anytime you splint something, they get a CMS assessment. Anytime there's something broken, CMS assessment. So, and then SPO2. All right, ALS request. This is part of your transport decision, and then in the very beginning of your sheet, you'll see like additional resources. So follow your local protocol. Like out here, if we have a semi tip over and it's got hazmat stuff, we call the hazmat crew, right? We don't go near it. Follow your local protocol. Same thing with ALS. Like if you have certain set protocol that says request ALS for X, Y, Z, every time you get on scene to X, Y, Z, request ALS if they're not already coming. And then consider if paramedics can actually benefit your patient. So as an EMT or as an AEMT, it is very surprising how much you can get done without a paramedic. We did it for 2 years. Got a lot done. And sometimes the paramedics just weren't available. And so you can do airway. You can fix the airway. You can fix the bleeding. You can fix the breathing sometimes. So consider what your treatments, if they need more treatments, right?
Just remember, pain management is not a reason for ALS. It is definitely a benefit. So keep that in mind. We did that for years, right? So like pain management stuff is great. It doesn't save a life. So don't be scared to pick these people up and take them somewhere. If you feel like you can get them somewhere faster than we can get to you, if that makes sense, right? Like that's where the best, closest option for the healthcare facility is. If you can get them to a ER quicker than I can get to you, like me and Becca, right before we finished paramedic school, had a lady go into VTAC on us, and she was in VTAC with a pulse, like just pretty as you please. We called it a paramedic, and we were like, freaking, how far away are you? And she was like, 35 minutes. We were like, well, we're 25 from the ER, so we're gonna drop real fast. Right, so like that's the kind of stuff you got to think about. It's like where this is going to benefit your patient more is waiting on us or taking another easy go.
And then the best or closest options for health facilities in the state of Nevada. It is per the NRS that you need to transport your patient to the closest, most appropriate facility. If I need to bypass this hospital for whatever reason, if someone got shot or someone's having a stroke and I'm in that time frame, I have to call this hospital and talk to the doctor and say, this is what I have. Can I bypass your facility? And that is for the state of Nevada. It's not like that everywhere. If you're working out here, if I'm having somebody with a heart attack, like I can see that they're having a heart attack, I'm going to bypass this hospital, and drive them right to Oakland if I have the means to do so. So Elko, although it's not my closest, it's my closest, most appropriate. Does that make sense?
Mm-hmm.
They have a cath lab. We don't have anything remotely close to that here. So. All right, so secondary assessment of the trauma patient. If they're talking to you and they're like, my arm's broken. Okay, cool, your arm's broken. If they're not talking to you, we're still gonna do like a full assessment, right? So we're figuring out the location of the injury or injuries. We're gonna assess the patient's mental status. That all gets done in the first little bit, yeah? The mechanism of injury, right? Look at that mechanism of injury. We're gonna look at that, we're gonna consider it. And then the patient's age or pre-existing conditions. So older than 65 usually is that level 1 trauma alert. If they're on blood thinners, if they're pregnant, all of that criteria, they get put in a more severe category. The intrusion of the vehicle, a death in the patient compartment, all of that stuff. So we're looking at that. Like this. If your patient's walking around and they're like, I was in that car, you're coming with me. Yeah, you need to sit down. Exactly. Yeah, so you can see obviously there's no patient compartment anymore. There's clearly intrusion into it if there was still metal, right? You're missing everything from here up. Like this is severe, so they need to go get checked out.
They're fine.
Yeah, this would be one of those.
That adrenaline stuff.
Yeah, this would be one of those, like we bring them to the ER and they're like, this patient's fine. And then we show them the picture of the car and they're like, oh, yeah, I can see it now. I'm trying to see how far the debris, had been scattered down the road. That gives you a pretty good indication too. How far is that debris scattered? Because that can tell you kind of how fast they were going. All right, so if they stub their toe, we're going to do a focused assessment, right? If it's very minor, if they fell onto their wrist and caught themselves, that's a focused assessment. Now, if they fell from the top of the building, that's a different kind of assessment, right? So determine their teeth complaint, conduct a history of present illness, figure out how the injury occurred. Yeah, they may have fallen. Did they pass out before they fell? The big ones, passing out in the bathroom. A lot of times people vagal themselves out when they're taking a poo and they'll fall and hit their head. Seizures can cause people to fall. There's a lot of things. The new up and coming that I've seen a lot is POTS. Who here has heard of POTS?
I don't remember what it is.
It's postural orthostatic hypotensive syndrome. Tachycardia. What did I say?
Hypotensive.
They do become hypotensive, but it is tachycardic syndrome. So that's a new up and coming. There's a lot of studies out there.
When you say up and coming, what do you mean?
So it's like one of those things that you'll see it as you work in healthcare. There's common diagnoses that you'll see that will come like more frequently because I feel like it's going to start if we're down the road. So doctors are like, oh, I don't know what to diagnose you with, right? When I first started in EMS, the diagnosis that they gave everybody that they didn't know how to diagnose was fibromyalgia. So you get 100 patients that are like, I have fibromyalgia. Everybody had fibromyalgia. The doctor didn't know what it was. So they're like, you have fibromyalgia. Now these people are passing out. They get tachycardic when they stand up, which you guys should know that that's common. That's regular. And they come in, they keep going to the doctor and keep going to the doctor. Doctor's like, I don't know what to diagnose you with, but I don't want you to keep coming here. So now you have POTS. So everybody's got POTS now. It's a new up and coming diagnosis. So.
But if you talk to cardiologists, it's not a real thing.
Yeah, it's about a 50-50 shot when you talk to a cardiologist or read like articles about it, because some of them think that it's complete bullshit, and some of them are like, no, there's truth behind this. So.
We'll see in about 5 years.
Yeah.
What
Yeah, we'll take it with a grain of
it'll
salt.
be something different. Kind of like the same thing with medications, like medications have their highs and lows. Like years ago, everybody was put on freaking Adderall and everybody was put on Ritalin. I grew up on Ritalin, and I went to Adderall. Like now, heart patients, everybody's getting freaking amiodarone. Freaking everybody gets amiodarone. Like, it's like the new thing.
Whereas like 20 years ago, everybody got digoxin. Like it's just, you'll see it come in waves with medicine. That's just how medicine is.
Medicine and diagnoses.
Yep.
Yeah, just depends on who's paying the most money to get their drugs pushed in.
All right. So history, what happened? How did this happen, right? Events leading up to. Did they fall because they passed out? A lot of times they can tell you, like, oh yeah, I tripped over this rug right here. Or I tripped over a small dog. That's usually the two culprits in like older folks' homes. Small dogs and rugs. They'll get them every time. What did they fall onto? Did they fall onto carpet? Did they fall onto hardwood floor? Did they hit their face on the way down? That's a big one. Falls in the shower. That's another one that you'll see a lot. So protective equipment used by patient. This is not only like your canes, your walkers, that kind of stuff. It also goes for like workplace. So were they wearing a helmet? Were they wearing a harness? Those kinds of things. And then actions taken to prevent or minimize injury. Did they try catching themselves on the way down? Did somebody else try catching them? Those are things that you want to obtain as you're getting a history as to what led up to whatever you got going on. And then areas of pain. So sometimes grandma falls, she tries to catch herself. She doesn't care about her wrist, but her shoulder hurts real bad, even though she taught herself like this. So sometimes it's like that force comes up and pushes onto the shoulder. Hips are a big one. People like to fall on their hips, break their hips.
Can't the hip cause the artery rupture too?
It can. Yeah. So a lot of times in older folks, that acetabulum, the joint that goes into their hip like this, is a ball and socket joint. It breaks off right at the head. But if you have any kind of like shearing force on that bone and it shards out, you want to be careful that it can cut that artery that runs right in the leg. Now, if you can see that, we've had patients where like one leg's this size and this leg is like clearly broken, but it's huge, swollen up. They're bleeding into that leg. I'm still going to put a tourniquet on them because you're stopping that bleeding inside. Even though there's no external bleeding, they're still bleeding into the. They got a leak.
You're supposed to turn it on the thigh area. You're not like splinting the pelvis.
I would still splint the pelvis and I would put a tourniquet on. Yeah, so your pelvis, right, that's going to be its own little thing. And then if their femur's broken for whatever reason, depending on how high up it is, if they have a mid-shaft femur fracture, I'm going to put them in a traction splint.
I thought you could do that. A traction splint and a pelvic splint?
Yeah, so you can. So depending on where their femur is broken, the pelvic splint is going to hold everything together. Now, if they have like an obvious, like really loose pelvis, I'm not going to do both. But we have our traction splits now. What's the name of it? The Shishman. Where they put the pressure on, you can do it if they have like a lower leg fracture on it because of where the pressure is put on our splits. We'll pull that out too.
That's why I say, I don't remember who asked me about that when we were doing the ambulance stuff. That's why I said you gotta be careful. If you don't put that thing on appropriately, you could still put excessive push force on their pelvis and still displace that injury. So you have to be very, very careful doing that. They say with those splints that you can do it based off of where those buckles sit and how that splint is placed. But you just have to be very, very careful when you do that. Because if it's very obvious and you put that opposing force, you can still put pressure on that. But
When in doubt, let's say we're concerned that we're not going to put it on correctly. Should we do one over the other, or is it situational?
the traction splint theoretically is really good at pain control. So if you're that worried about it, splint the femur and stabilize the pelvis.
So there's other ways to put traction on a leg, right? So if I'm really concerned about both, say that pelvis is just crushed, I'm not going to go putting a traction splint on. You can still have manual traction, or I've seen where you can take like their ankle and pull it, and if you like have it on the end of the bed, you can wrap it around the end of the bed, and that will provide traction.
Or
So it's
if you have,
kinda
like,
works.
something heavy that you
Yeah.
can like put on their foot and like pull traction, it'll kind of pull. Because if you watch ortho doctors and like trauma bays, they take like sandbags and they'll pull traction, like that manual traction, and they'll just tie like a sandbag to their leg and let it hang off the side of the bed, so it holds like the manual traction, so you ain't gotta sit there and just hold it. So there's ways around it, you just gotta MacGyver.
Yeah.
Those traction splits work really well for pain relief, though. They get really, really mad at you for like 10 seconds, and then they're like,
They work better than any pain meds. Like if someone's femurs and you're over there pushing a bunch of pain meds and they're like screaming at you, and then as soon as you pop that bone back where it's supposed to be and you hold traction, it's like I feel so
You guys, is yours the rod ones?
There's-
the rod, it's got like a strap up top and like an ankle strap or like
Yeah,
a strap.
it
that
goes
over the
here and then here and then here. So you can like put the pressure wherever you need to put it, depending on the patient.
door. And they work, you just gotta be careful.
Follow the colors, right? Just follow the colors.
I don't think ours are colored, ours
Ours
are
are
just,
just red and black.
yeah, we just have like a black like buckle strap for the top and then like a Velcro strap for the bottom.
Yeah, because the other ones, depending on which ones you use, can either go up into the groin, and that's like you're pushing up into the groin to provide that traction. And there's one that sits on the outside of their leg, it like sits up under their hip and it pulls out the head. So this one wraps high up on the leg still. So it's kind of just taking that bone and stabilizing it rather than using this. If that makes sense. We'll pull them out whenever we get to that chapter. All right, so areas assessed depend on injuries and chief complaint. We're gonna look, listen, and feel, right? Look, listen, feel your patient. Okay, so we're gonna assess bilaterally, right? We went over this this Tuesday. So are they matching? If someone's like, yeah, I rolled my ankle real bad and it looks like this. Yep. So clearly it's asymmetric, right? They're not the same on both sides. All right, palpate. We're gonna actually really palpate. We're not gonna do this. We're gonna palpate. Check the temperature of the skin. You can feel it through your gloves. If you can't feel it very well through your gloves, pull the back up and feel with the back of your hand. But usually you can feel it right through your gloves. Texture, that's another thing. Like with hives and stuff, you can get bumps. If someone has like burns, you can feel a different texture, that kind of stuff. All right, auscultation, we're gonna listen. I will say the best way to auscultate somebody's lungs is put your stethoscope directly on the skin. So go up under their shirt and to actually listen to their back rather than their front. And then if you can tell them to breathe through an open mouth, like it's easier for you to hear. So rather than going, you're gonna hear it better if they keep their mouth open. So whenever we're listening to the back, we're listening to upper and lower lobe. So listen here on the skin, listen here, 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 here. And then if you want to listen to the other side, you can do that too. You're going to hear it better on the back. I will say sometimes patients are like, and you can't get to their back. That's fine. Still put that stethoscope to skin up under their shirt. So if you're listening on the front, here, 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 and here. So you want to listen to upper lobes and lower lobes of their lungs. And then listen to bowel sounds. So if you put your stethoscope on someone's belly, you can hear it going, just like that. Yeah, so if they have no bowel sounds, yeah, so you listen for a little bit, wait for like a minute. They should make at least one every minute. If they have more than that,
Technical medical.
Yeah.
term.
yes, I can't say the actual word. It's borborygemi or some weird.
I like the other term better.
So you listen. If you don't hear it at all, and they're complaining of like bad abdominal pain, it could be a sign of like a a blockage in their like valve obstruction. Thank you. Or if it's like overactive. Sometimes if someone's been puking a lot, you'll hear overactive valve sounds. Or if you eat Taco Bell, what's your fiber intake? All right, BCAP BTLS. Frank, what's D?
Don't know.
Who wants help? Deformity.
Everybody.
Steven.
Crap.
No.
No.
Huh?
Circulation.
Who wants help?
Contusions,
Contusions. Got it.
abrasions.
Oh, great. Andy.
Punctures and penetration.
Good.
You're cheating.
Allie.
I see you looked at it.
Harlan.
Tenderness.
Good.
That's not cheating.
Andy.
He knows where to look.
Yeah, he's cheating. He's reading so he doesn't know where.
Well,
We're on L.
oh, well. Laceration.
Marissa. Good job. Jessica.
Huh?
Oh, wait.
That was the last one. Don't ask
Trick
another
question.
one.
Trick question.
I saw a video of those girls and how to her angels last night on TikTok.
Really?
You know, it's so funny because I can remember back when I was doing EMT school, trying to learn like the sample, go PQRST and all that stuff.
Now there's music about it.
Now I have to think about it to remember the things.
OPQRST, decap ATLS.
So C, contusions or crepitus. What is crepitus?
Bones and bones.
Crunchies. Yuck.
Like chips.
Como se dice yuck?
Yuck.
Good. All right, so baseline vitals, we take at least 3 sets. Early vitals are important. Try to get those first set of vitals within your first, ideally 5 minutes, but 10 minutes of patient contact. That should be like your first little bit, right?
Depending on who you ride with, like, if you ride with like me or Becca specifically, when we come off the back of the truck, the one thing that we're gonna grab, if nothing else, is gonna be the monitor. And so when we walk in, whether it's, you know, Billy or Marcus or whoever the second person is, will start getting vitals like immediately as somebody else is talking to the patient. That way we have like a quick set. So.
Yeah. All right, spinal motion restriction. If you are gonna put a C-collar on, make sure you're measuring it correctly. So you use your fingers. You go from where their little trap comes up to the bottom of their jaw. If you need 4 fingers, you're gonna check the bottom of the collar. When you strap the collar.
That's what they consider no neck.
If you have, you're probably.
Oh.
What you get for hitting your protein?
He's like, man.
Going out looking at her, be like, man, stretching, and then. So no, real got, I got one.
Start watching the
Real
lamp.
big, so my neck is stretching.
That's what I thought you were asking, like, no neck, yeah, no neck. Like,
They know.
Look at the view.
So somebody with hoodies, somebody with their hair down, this is gonna suck. So hoodies are the worst. I freaking hate them when I'm putting these on. We don't really even use these hard collars anymore. They're statistically causing more problems than they are solving. If we are really putting on a C-collar, we use soft collars now. So remember that these, either one, is not there to completely immobilize a neck. It is there to remind the patient not to move their neck. If someone's alert talking to you, this isn't going to keep them from turning their head. If they're turning their head, chances are they probably don't have a spinal injury anyway, unless they're just that altered. I thought you were raising your hand. I was like, say something. I knew. I knew. All right. So as I'm measuring it, 3 fingers, 4 fingers, however many. You want to help me out here? So bottom of the neck. Oh yeah, good. Bottom trap to the bottom of the jaw. So yes, you have a neck. I realized I had this coming out of my mouth. Like, oh.
I'll take it, she just hangs out with me.
It's a Hutto thing. I think like it's an acquired an acquired thing where I just say what's on my mind. I don't know. It's because I've been hanging out with him too much. Anyway, so 3 fingers. This moves up and down.
Is that there some light on it? Or is that like a glittery stick?
It's a little glittery sticker.
Okay. I was looking.
So as I move this up or down, I'm gonna go 3 fingers. So most people are gonna be like short. We're gonna lock it back in place. Now as I put this on, I fold this back behind to see how it's kind of messed up. So I'm gonna slide it again from the hoodie. I'm gonna slide it behind their neck, and then I'm gonna scoop it down, pull it down, and scoop his neck up and. No, don't put it on like a freaking Batman mask, like I've seen that. Don't put it on upside down.
I've seen that too.
Yeah.
Roll up in the fire department's got it on like this. Appreciate it, guys. Y'all did great.
Yeah,
Thanks.
y'all did really
Take this home.
What if they have a stoma?
There's a
They
hole
still
in
have
it.
the whole thing? Yeah. Still work.
Now, if
So-
you're like, if you're bagging them through the stoma, you're trying to get around it. This one doesn't have a hole.
Yeah, you can cut a hole in it, but like realistically, the only time we like really use these is if we're intubating somebody. Sometimes we'll put these on just to like hold. Because these are actually, they're pretty good about holding eggs still. And I think that's part of the reason why they like, they're not good for you, right? Because there's so much like pressure on these things. They're so hard, they can like create sores and stuff. So they don't really like using them. But if we have somebody like intubated and I really need them to freaking keep their head still, then we'll stick one of these on them because it'll hold their head upright. So they can sit there and bump it in. Yeah, so that'll hold.
Yeah.
So,
There's a little dot right here where the chin is. There's a little thing that sticks down too. That should be right in the middle of their chin. So to get that, that's that scooping thing that you do.
same thing with these. Add a little freaking chin rest form, right? These things are oddly sized. So like, we'll get like the large ones and they don't like wrap around their head all the way. Cause like, even this one, like I got to kind of work. I got to kind of work to get that thing on. So these things are kind of oddly sized. If you have to like go through 1 or 2 of these to get on, right? We don't really use them that often, honestly.
Yeah.
The flight crews like to put them on because what we have found is trauma teams in like big cities. For some reason, they're like, why don't they have a C-collar? So the flight crews will come in a lot of times and be like, I'm just gonna put this on so I don't get yelled at when I get down to Reno.
Yeah.
So,
And sometimes like adults don't fit in these. So like really tiny adults, they'll fit better in a kid's, like a pediatric one. If I have a patient that like this is just not gonna fit them, and I know it because they look like that guy from 90 Day Fiance. Y'all seen it? Yeah, he's not getting a C-collar. So what you can do is take like a towel or a blanket and roll it up and make it look like a rainbow over their head and tape it across the forehead if you're really that concerned about it. Follow your local protocol. All right, assess neck. Someone's holding manual seems fine, don't worry. We're gonna measure it. We're gonna put the collar on.
it's so funny because when you go to put these things on, you're like, I gotta move your neck real quick. So I put this thing on and you're really on a stretcher. You're like, I'm gonna move your neck around. We're like, all right, don't move anybody. Just like,
So we're not supposed to move them, but how often are they actually going to have their head in that position that we want them in for the C-collar anyway?
Yep.
So you still gotta,
you still gotta move
still
to
gotta
get them
move.
there. Yeah.
And so like the big thing about putting somebody's head who's like you're concerned about, you're still moving their head to a neutral inline position. So you could show up with their head to be like, and you still have to move it like this. Now I've never had a patient this way, but I've heard of it where they're like something's pulled or broken or something here and they physically can't move their head back. I have had patients that have like scoliosis or like some weird spine thing, like chronic, that you can't like physically move their head. We had that lady the other day, her head was stuck over here. But if it's from trauma, don't like, if you meet resistance, don't be like, you know, but you should just grab their head.
have you ever moved it and it like make crunching sounds?
No. You hear
That's
that
good.
one like freaking 90-year-old man, it's like, that one time I was on the fire department, and this guy's head, he died. No, he didn't.
Yeah.
Okay.
So,
Feel the pop, he's like,
yeah.
you're like,
Bro.
"Go back."
Like, I'm gonna put that one down.
From everything that I've read about it, and we have resources too, we'll show you guys the studies whenever it's talking about sea collars. What they're finding is that any kind of like serious spinal damage is done before we even get there. And then that spinal damage that's done, sometimes those symptoms don't show up till after we get there, or like during transport or at the hospital, because that spinal cord will actually swell and it puts pressure on those structures. And so that's where those like weird things show up later. If you have somebody with a broken neck or a broken back, they're going to tell you about it. That hurts. Just like you would break your arm, you're going to splint your own arm. You're going to hold it close to you where it's comfortable. They're not going to want to move their neck around, right? So a lot of times, I'm not going to put them on a hard piece of plastic. These are hard. They hurt. The amount of patients that I've had that have requested me to take this off of them because it's causing them pain is more so than somebody. I have had patients that have asked for them because they want to.
Well, you got involved in it, so Taco Bell, it's like, I need a sea collar. Oh, you ain't even got a scratch on your car.
Yeah.
Well, we put a sea collar on her and she took her out to the waiting room.
Yeah.
Yeah.
Mhm.
She had no damage. She's sitting there, she's like, can I keep my food?
Yeah.
Sit right here on this bench.
Yes. All right. So serious injury, multi-system trauma. So a lot of systems affected in one trauma is a high priority. We're gonna spinal immobilize. Putting them on a stretcher counts as spinal immobilization. Okay, if they're laying flat or semi-fowlers or like that weird in between, that is considered spinal stabilization. We're going to consider ALS, of course, and then we're going to do a rapid trauma assessment. So here's our CMS. I'm going to run through a rapid trauma assessment. Billy?
You got voluntold.
He's a trooper. All right, so how many of you guys have your sheets? Or someone next to you has their sheet?
You want the trauma one?
Yeah, the trauma sheet.
Oh, yeah.
Okay.
It ain't that not hard.
You want it or do you want us?
Are they those ones?
You want it or you want us?
No, you guys will.
Oh, okay.
So, under your little rapid assessment, trauma assessment, we're gonna run through it real quick. I'm gonna slow it down. You're not even helping me. Give me some. This should be done in like less than 3 minutes. This is a rapid trauma assessment. I'm gonna slow it down and I'm gonna go through it like a normal. So whenever you guys are doing your scenarios and you're doing a rapid trauma assessment, you'll learn to go fast, right? But slow is smooth, smooth is fast, right? So we're gonna learn it slow first. We're gonna get good at it and then it can kind of get the speed from there. So, Billy, he has been voluntold to be my patient today. So I'm going to start at the head, right? So we're checking the head. Our ABCs are done. They're taken care of. Secondary assessment, right? I'm going to start at the head. I'm going to palpate. I'm looking for deformities, contusions, abrasions, punctures, burns, tenderness, lacerations, or swelling. Okay, DCAP, BTLS. So as I palpate the head, I'm going to use the tips, not the tips of my fingers, but the flat spots of my fingers, right? So we're palpating. Okay, DCAP, BTLS. I'm gonna.
Feels like that you.
I know.
Why are you touching me?
Oh, I'm sorry. May I touch you?
Okay.
Thanks. Have you guys seen that girl on TikTok? She's like, for the hair consultation. She's like, do you mind if I touch you today? Why do you think they're there? Like, yes. All right. So palpate the head, looking for DCAP, BTLS. I'm looking in the ears. We're looking for any drainage that could be potential sign of like a head injury, right? So looking in ears with my light.
If there is the drainage or whatever, do you take like a piece of cloth or something?
Yeah,
to halo thing?
Yes. Yeah.
I can show you a picture of pretty large thing.
Yes. Yeah, we'll show you what the halo test looks like. So I'm looking for drainage in the ears. I'm gonna look behind the ears for something called battle signs. They get bruising behind their ears whenever they have a skull fracture. Just know that the bruising behind the ears, that comes later. We still look for it, but that's not something that's gonna show up right away, right? So I'm looking for battle signs behind the ears, okay? Now I'm gonna move down to his face. My hands are cold. I'm gonna palpate his cheeks and his jaw and his forehead. So as I palpate, looking for decap BTLS, right? I'm at the face. I'm gonna look at his pupils. We're gonna shine a light. Are they pearl? Are they equally round, reactive to light, and accommodating? Okay. We're gonna look for any drainage out of his nose. We're gonna open his mouth. Gonna look for any kind of bleeding, any kind of misaligned teeth. If someone's able to talk to you and you're suspecting a jaw trauma, have them put their teeth together. And if they feel out of place, then tells you that the jaw could be broken or dislocated or something. Usually they'll know if it's dislocated. All right, now I'm going to move down to the neck. We're going to palpate. I'm looking for JVD, so jugular venous distension, which could be a sign of a pneumothorax, pleural effusion, or pericardial effusion. And I'm going to look for tracheal deviation. So we say look for tracheal deviation. You're not going to really see that either. It's going to be something you feel. So what happens is that trachea will move to the good side if they have a collapsed lung. Again, that's not something you're going to see right away. That's something that develops later, but we're still going to check for it. So
If you're seeing that, then probably.
yeah, I've only seen it once in a half alive patient. She got hit by a car and they didn't find her until hours later. So I'm going to feel his trachea. We're looking for tracheal deviation. All right, now I'm going to move down to his chest. I'm going to palpate his clavicles. I'm going to palpate down his sternum. So if he says ouch, or if I see any injuries throughout this whole assessment, I'm going to take note. If it's like bleeding majorly, I'm going to fix the bleeding. But as you're doing this, you're like, I take note of that. That's how this goes, right? So palpating the sternum, and then I'm going to palpate his ribs. Are you too close? All right, I'm going to go like this and have him take a deep breath in with my thumbs side by side. So my thumbs move together. That shows me that he's got equal chest rise and fall. Okay. I'm going to expose his chest. I'm not actually going to, but I'm going to expose his chest, look for any. Don't mess with me, no scissors. I'll pull them out. One of the nurses over here goes, Mika, cut her pants. Yeah. Yeah. So I'm going to check his chest for any bruising, right? Any bruising, decap, BTLS. I'm going to move down to his belly. I'm going to palpate. If he is complaining of pain, I'm going to start from the point away. So palpate. Okay. I'm going to take note he has tenderness in his right upper quadrant. Okay. From here, I'm going to go to his hips. I'm going to feel his hips. We're going to push in on the side. And then they used to teach that you grab and rock their hips like here and push down. Don't do that. Don't do that, please. If someone has a pelvic injury or pelvic fracture, you're going to exacerbate it by going and putting your whole weight on it. That's how they used to teach it. We don't do that anymore. We just.
It's like, hey, does this hurt? Let me make it worse.
Yeah, exactly. Does this hurt? Crunch. Oh, now it really hurts. All right, so from his pelvis, I'm going to look for a priapism, right? So what's priapism?
Sad boner.
It's a sad boner, exactly. Back of my hand.
Sad boner.
Like I'm done. Right?
No, most of my class last year was ERT folks, so I heard that a lot.
Yeah, it is the sad boner. So if someone has a spinal injury, it's not a good time for them. Okay. So assess, don't caress. With the back of my hand, I'm going to sweep, right? Check for priapism, which is indicative of a spinal cord injury. I'm going to say that as I'm doing my assessment. Now I'm going to move down to the legs. As I check long bones, I'm going to put opposite opposing force, unless there's an actual obvious deformity. So I'm going to go here and I'm going to push from each side, and I'm going to do that down both legs. So what that does is if there's a bone that's broken, you'll feel the crepitus in it. Whereas if you're just palpating like this, it might not move. But if you're putting opposing forces on it, you'll feel that crepitus. Does that make sense? Yeah, the crunchy. So once I've done both of his legs, okay. I'll do it when I go fast. So now I'm going to check CMS. Okay, pulse, wiggle your toes. Very good. Push down like you're driving a car. Good. Pull up. Can you feel me touching you?
Yeah.
Okay, very good. All right, now I'm gonna go to the arms, do the same thing, opposing forces down his arms, right, both sides. Pulse. Wiggle your fingers. All right, close your eyes. Am I pinching or scratching?
Pinching.
Good. Now we're gonna check the back, right, so we roll them. Very good.
Hey, what you call it that one day?
Oh, we're not doing rectal tone.
He's like, hell no.
All right, Billy, ready? No. So we're
That's
feeling down his
out of your
spine.
scope of practice.
Who said? Who said?
She freaking touched on Calvin's butt.
I didn't put my finger up Calvin's butt. Don't get that twisted. I had exposed one butt cheek, and I'm never gonna hear the end of it. So as we check his spine, we feel down the spine. We're looking for any step offs of the spine. As Billy pointed out, and he is absolutely correct. As I came to the neck, I should have felt up here behind. When I was up on the front of the neck, felt the back. Yeah, that was my back. So I'm going to feel all the way down his spine, tenderness, step offs, that kind of stuff. I'm going to do a sweep of the butt. All right. So if it's dark outside, that's why I don't love the black gloves, because if you sweep and it's got blood on it, it looks like water. If you guys have ever seen blood on black gloves, you can't tell. Orange gloves, lighter colored gloves, those are better. You do a sweep, look for mud or blood. Or is that what they mean by mud?
Yeah.
Okay. I was like, mud or blood. That's what I'm looking for. So that should be done in less than 3 minutes. Ooh, in here it feels like they could do that in less than 3 minutes. Everybody's hand should go up because y'all gonna be able to.
Get him,
Oh,
Ethan.
he said
Yeah.
he could.
Let him do it. He should be the next.
You should. Mhm.
Like on, when he said ow, when you touched at the second point, would you just go directly down to the lower quadrant on the other side then?
Technically, yeah. Mm-hmm.
Because that.
That
the first
hurts
one
up
was
here.
But then you go over here and he said ow,
Yeah.
so you would go down
Opposite.
here
Yeah.
and see what's going on down there, right?
Absolutely.
Okay.
Yeah. Good point. Good point. I like it. I like it. All right. So I'm gonna do it fast now. I'm gonna see if I can remember everything. Y'all test me. I haven't done this since last year.
Put them on the table.
You wanna lay down on the table? Will this table support?
I can lay down over there.
Yeah, you can lay down.
Yeah.
And he's like,
Hey, go pick him up, put him on the table.
Very good. I like it. Okay. All right, real time. Yeah, someone's already having.
You got, you can hold that for him, so you can hold it up to the table.
Oh, thanks. Is she even online? I keep hearing her leave. Ready? Yeah. Set. Go. Okay, so I'm gonna palpate the head, looking for deformities, contusions, abrasions, punctures, burns, tenderness, lacerations, swelling, and details. I'm gonna palpate. I'm gonna look into his eyes. I'm looking for pearl. If they're unequal, that tells me it's a sign of a brain injury. I'm gonna look in his ears for any drainage. Behind his ears for battle signs. Again, a sign of a head injury. I'm gonna palpate his face, his head, his cheeks, looking for any DCAP BTOS. I'm gonna move or look in his mouth. Any bleeding, any airway stuff that I didn't fix before, I'm gonna fix it now. All right, neck, looking for JVD, any tracheal deviation. JVD tells me there could be a pneumothorax or an effusion going on around his heart. Tracheal deviation will be a sign of a tension pneumothorax. I'm gonna move back to the back of his neck and check for any step-offs. I'm gonna palpate his clavicles, check for any DCAP BTLS, down his sternum. Take a deep breath for me. Equal chest rise and fall. I'm going to check his ribs. I'm going to palpate his belly. All 4 quadrants. Check for any tenderness, rigidity, distension, that kind of stuff. Priapism, back of my hand, tells me about a spinal cord injury. I'm going to check his pelvis. It's stable. I'm going to move down, check his legs. Any deformities, DCAP BTLS, both legs. All right, pulse, wiggle your toes for me. Good, can you feel this? Very good. Up to the arms, same thing. DCAP BTLS, DCAP BTLS. Pulses. All right, wiggle your fingers. Good, am I pinching or scratching? Continue scratching. Very good. All right, now we're gonna roll him. So my partner and I roll. We're gonna check down his back, any step offs. We're gonna do a sweep for mud or blood. Now we're gonna roll back. Still got it. All right, now.
Yeah, it's your turn. No, I come in at the turn yours.
Oh, yeah.
He does, yeah.
Thanks, Billy.
I'll show you how to make
Billy
those.
knows, his class tried to beat.
Huh? I'll show you how to make those. at your
Yeah.
birthday. She probably.
I was running out of breath. All right, so now who feels like they can do that?
Maybe in 10 minutes.
Everybody can do it.
Not say everything, but I can do it.
Yeah, good. Practice, right? So we're gonna practice doing that on each other.
So when it comes to doing all these assessments and stuff, if you say DCAT BTLS the first time, I'm gonna ask you what that means. After that, you don't have to repeat it. But the first time, chances are I'm gonna ask you what that means, because I need to know that you know what you're talking
I
about,
just
right?
want to off my.
OPQRST, sample, all that stuff. If you go through and you're like, yeah, I'm looking for onset, provocation, quality, severity, radiation, tenderness, or time, cool, right? But if you say OPQRST the first time, I'm gonna ask you what it stands for. So just keep that in mind, when you're doing these assessments, if you're just like, yeah, I'm looking for DCAT BTLS, and I'm like, okay, what does that mean? And you're like, dang it, crap, frickin' poop. Yeah, so, yeah,
All the
looking
bad
for
things.
bad things. Yeah, so just know what that stuff means.
So when you're doing the head to toe, you start doing the legs and arms. You just go down the body and just like start with the chest and the abdomen, and you go to the arm, and then
Yeah.
go to the one side of the leg, and then move up to the other side.
Yeah, you could absolutely do that, but the only thing that I would say is when you're checking pulses, try and check them bilaterally at the same time. But other than that, yeah, absolutely. So you can go down. As long as you hit everything, if you find whatever your groove is, just follow that as long as you're hitting everything. And even like if I walk up and they're like, say they got ejected and they're laying on their prone, you can start out with back. You don't have to start out, like do that real quick, flip them, do the airway stuff. Again, like real life's a little bit different, right? According to the National Registry, you're gonna flip them, do the ABCs and all that stuff. I would start just, what do I feel on their back? And then flip 'em.
What is it indicative of if their pulses are not the same bilaterally?
So we were talking about that aortic aneurysm. That could be a cause of it. Another thing that can cause it is like if they have a broken bone and they don't have a pulse in that extremity, that would be a problem as well. Another thing, like more medical side of things, like your DVTs, like your blood clots in your arms or legs, and
What's
they
DVT?
lose deep vein thrombosis. So if they have a clot somewhere and it's stopping blood flow and they don't have a pulse there, that would be another thing. That would be like ding, 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 like high on my list.
Excessive swelling, like compartment syndrome.
Yeah.
So if somebody gets like a broken bone and they get excessive swelling in that extremity, you can cut off blood circulation like that and start developing like compartment syndrome. So that's another big one.
Yeah, yeah. I think what else? PEs can cause it too.
Yeah.
So, yeah, but that's something you want to check is pulses, both sides. So, all right, this is that battle sign that I was telling you about. So if you're seeing that and you're suspecting head trauma, that can be a sign of a skull fracture. Again, that doesn't show up right away. That's not something that as soon as they pop their noggin is going to pop up. It shows up a little bit later, but we still look for it. This is that seatbelt sign. Any kind of internal bleeding into the belly can show up as a bruise. Do not think in your head, oh, they don't have bruising, they're not bleeding into their belly. Our bellies can hold up to 1 liter of blood before they start to show any outward signs, right? That's a big space to fill. So do not say, oh, their belly don't look like this, they're fine. Don't do that. All right, bilateral, the chest thing, you saw my thumbs move together. This guy looks like he's having a great time. Yeah. So. All right, roll patient on side. Whenever we're rolling them on their side, Billy kind of rolled himself, so it was really nice. But if that patient can't roll themselves, for whatever reason, you need to have someone hold their head like he is here. But take their arm on the side you're rolling them to and move it up so they don't roll onto their arm. So move their arm out of the way. And then if they have any like obvious broken bones or anything on one side, roll it on the opposite side. You don't want to crunch their already broken bones. So, they don't really do it here. Ideally, you and your partner, when you roll the patient, you should not interlock, but cross your arms over like this. So shoulders, hips, legs. So you're crossing over as you roll them. All right, kiddos, fontanelles are that soft spot on kids. Don't do that. Don't go poking. So don't poke into their fontanelles. If they have brain swelling, you'll see it. The fontanelle will bulge. Or if they're bleeding out, sometimes if they're hypovolemic, that fontanelle will sink in. So just make sure you're looking at that. Kids are obligate what breathers? Mouth or nose? Nose. So if they have mucus or blood obstructing their nose, they're going to have a lot more difficult time trying to breathe because they're obligate nose breathers. And then they're big old heads, right? When they fall, kids always fall like this because their heads are heavy. So increase of chance of spinal cord injury. Was it you that got the question on your NREMT last year about the kid that got hit by the truck? And it asked what injury pattern you would see?
Not injury pattern. It asks like what the secondary assessment.
Okay. I think somebody got a question about like an injury pattern.
Yeah, I think it's been done.
Was it Smith? So they got a question on their NREMT about like a kid getting hit by a car, like what injury pattern. And it's fine because their heads are huge. So. Another thing you'll see with kids, I don't know why it's not in here, where that seatbelt sits on kiddos, if they're not in an appropriate car seat, they have a lot of abdominal trauma from the car seat or like the seatbelt because of where it sits on their belly. It doesn't sit across their hips like it would for an adult. It comes up onto their abdomen. And so we see a lot of like spleen, liver ruptures, that kind of stuff. So. All right, we're explaining the patient what we're going to do. We talked about that. Don't go just ripping clothes off of your patient if they're, no, even if they're unconscious. Hey, we're going to check you out because we don't know what they can hear. Expose the area, expose the chest, expose the belly. If it's a bad trauma, get them trauma naked. Don't even test me. I'll whip these things out.
Well, they don't have a serious trauma.
Cut your toes off.
These things are awesome though. Have you guys messed with these at all?
You got a dirt bike? No?
Smart.
Yeah.
They're dangerous.
These things can cut through
I
pain.
know
That's
it's
old Smith's kid. I'm gonna catch him on the freaking side of the road one day. He's on freaking riding that dirt bike around. Yeah, he's riding around all over the country, I was on freaking hell and all that. So one day I'm gonna pick him up on the side of the road.
They don't watch for
Yeah, I've got to call a snitch on him. Y'all see his kid riding around with a helmet on, acting like a ding ding, call a snitch on him. I do it all the time. I do snitch on all, everybody's kids. Let me catch one of you kids out acting like.
Still alive.
Sure, why not? Go for it.
All right, so your secondary exam, it's okay to do this en route to the hospital. It's actually preferred. So don't waste time on scene trying to do a secondary exam. Do while you're en route. Again, if you are too busy maintaining the ABC part of your assessment and you can't get to the secondary assessment, it's okay. Like you're so busy trying to get this person to breathe or get oxygenated. Don't concern yourself.
The biggest thing with that is if you're stuck in one spot, make sure that you're watching your patient well, for anything developing. You know, we've had before where we've had people shot a bunch and we missed a bullet hole, right? So like, pay attention, your patient might be bleeding out of their back, and like maybe you didn't see it the first time, and now your patient's starting to get a little wonky and their blood pressure's starting to drop, and you look down at the stretcher and it's covered in blood, right? So even though you might not be able to do a full detailed secondary assessment, keep watching what you can while you're maintaining the ABCs for any kind of changes in the patient.
All right, again, critical interventions, do it after. We just talked about all this thing. All right, chapter 16, reassessment. So that is this part, your little sheet. All right, so we reassess. We're going to repeat key elements of our main assessment. If you see something like major, let's say we put a tourniquet on somebody for whatever reason, they're bleeding out, we're going to reassess that tourniquet. Because chances are sometimes we put a tourniquet on and our patient kind of moves around, that thing can get loose. Sometimes, even though that thing's super tight, especially on legs, you might have to put on a second tourniquet, like if they're still bleeding out. So those are things that we reassess. If we're doing any kind of airway intervention, we reassess. If we're doing any kind of medication administration, we reassess. We want to see how our patient is responding to all of our treatments. So this is where we get our changes and our trends. Again, I will say your patient doesn't just suddenly decomp, you just suddenly notice. So there's always subtle clues that something's coming. And trust your gut. If you look at a patient and your little gut is like, they're about to code, listen to that. They might not code, but more times than not have I had a patient and I'm like, they're gonna die. And then they freaking die. So make sure you're trusting yourself. We got spidey senses for a reason. So whenever we're assessing a patient, make sure you're keeping them informed. It's scary for them, especially whenever we're doing all of things like, hey, warn them you're about to meet a lot of people really, really fast, right? So warn them what's going on. Explain to them the procedures that you're going to do. If you're going to do a 12 lead, explain like, hey, I got to expose your left breast. I got to, and if they're like, absolutely not, okay, but whatever. Consider your patient's feelings. Some of us have empathy problems. Fake it till you make it. That's all I got. Do not be the person that says you don't need to care about your patients to be a good provider. Do not be that person. If I hear that come out of any of y'all's mouth, I'm going to have some words. Billy didn't say that.
Pulls out a sign, he's like.
Yeah, he would. Billy didn't say that. Yeah. Billy's very familiar with somebody who did say that, but that's another story. All right. Primary assessment, we start from the top and go down. So secondary assessment, reassessment, start at your ABCs and then go down again. Hit all of the critical points. So what if you are working in cardiac arrest and you get pulses back? Where do you start your reassessment? Respiration. Airway, breathing, circulation, right? So you're working cardiac arrest, you get pulses back, you're ready for your reassessment, you start back your CABs or ABCs,
At
whatever
that
you
point,
want.
that is a new patient. That's what you need to think about that as you have now received a new patient. That is no longer your dead patient that you were just dealing with. This is a new patient. Now we need to reassess what caused them to go into this cardiac arrest and how can we prevent them from re-going into cardiac arrest.
So start with your ABCs, recheck for life-threatening problems. Again, the tourniquet placement, if they were bleeding out and you warranted a tourniquet, check that tourniquet placement. I'm going to harp on that because that's something that I've seen. Somebody put a tourniquet on and then my patient's crumping. Why? Because they're bleeding out again. Every 5 minutes for unstable, 15 for stable, 10 minutes for your stable trauma patient. Their unstable trauma patient, that's every 5 minutes again, right? Your chief complaint may change. Sometimes it changes as you're getting them into the ER. And you're like, yeah, they have chest pain. I did all the chest pain things. Then you walk them in there and they're like, or you roll them in there and they're like, I've never even had chest pain. You're like, liar. I treated you for the chest pain. Yeah, patients like to make liars out of you. It happens. Yeah. So, now if you have a patient that's like, hey, I can't breathe, and then now they develop chest pain, like those are things that can happen too. So talk to your patient. Any anticipated changes with your treatment modalities? So if I give albuterol, I expect their breathing to get better, right? If they have chest pain and I give them their nitro, I expect their chest pain to get better. I might need to re-give nitro. So we're assessing everything. All right, interventions. Check the patient's response to all of your interventions. Make sure that you're charting that. Because if I give something and they got better or they got worse, I need to document all of that. So oxygen administration, bleeding control, medication administration, all that. And then identify trends. If you have a patient for a long time, sometimes you can see subtle changes in trends. Sometimes you don't see any changes in trends, but make sure you're looking for them.
Because the natural can drop the blood pressure, you always have to take their blood pressure first
Yes.
before you get into it. Even if they're like in the middle of a heart attack,
Yes.
no matter what, you have to.
Yeah, always, anytime you give medication, before and after. Anytime you do an intervention. If you put a tourniquet on somebody, before and after. Doesn't matter.
And that can also change like how often you check vitals too, because like if I check vitals and 3 minutes later I give nitro and say they're somewhat stable, I'm still going to check their blood pressure right after I give nitro because that can dump somebody's blood pressure. So I'm just going to reassess it.
Because if you give them nitro and the first blood pressure you take is after you give the nitro, your blood pressure is 80 over 40, or their blood pressure 40 days, right? Because if their blood pressure was already low before you gave it, and then you gave it, well, now you made a no, that's no. But if their blood pressure was fine before you gave it, and then it tanked it, obviously now you're like, oh, I'm not doing that again, right?
That kind of goes the same, like say their blood pressure was like 160 over 90 and I gave a nitro tab and their pressure dropped to 110 over 60. I'm not going to give, you can give up to 3 doses, right? I'm not going to give a second dose. If the first dose dropped them that much, even though they still have that blood pressure where they could take another one, I'm not going to give a second one, if that makes sense. So it kind of puts that baseline, like you want to see where you're starting out from. All right, what questions y'all have?
Dang, that was a big joke.
Hey, check.
So remember, this was like, I don't know if you noticed, like Becca looked at Billy and was like, what did I miss? And Billy was like, oh, you missed that. Billy worked really hard to be a good EMT, right? And so Becca isn't afraid to look at Billy and be like, what did I miss? And Billy called her on it, right? There's nothing wrong with that. You gotta be good at what you do, right? That's what all of this is about, is being good at what you do, right? Be really good at assessments, be really good at talking to your patients, identifying their stuff, right? Because that's what's going to define who makes good providers. So get good at this stuff, practice at home, practice on each other, whatever you need to do. Get good at those sheets. Those sheets, they don't use for like the National Registry skills test anymore, but they are fantastic, like baselines. When you start riding with us, you'll notice I'm not like, size, my seem safe. Okay. Do I need to call additional resources? Okay, I'm considering C-spot. Okay, ABCs. Breathing, right? So I'm not gonna sit there and just like go down there and shoot. But I also do everything on that team, right? So I hit all of those little points, even if it's subconsciously, right? Like I'm gonna walk in, half the time I have my clothes on. That's neither here nor there. But I'm gonna walk in, I'm gonna do these things subconsciously, even if you're not seeing them. And so once you get those beats down really good, you're gonna do it subconsciously. Right? So like, even if you don't think about it, you're gonna walk in, and I'm not gonna walk in and just stare at somebody's mouth and be like, are they breathing? But subconsciously, I'm looking at their breathing, right? And that's airway breathing, right? Like that's what you're doing subconsciously. So get good at those sheets, because then it just kind of becomes like a subconscious thing, and you don't have to hit every bullet point because you're doing it anyway. You just don't think about it.
Yeah. Okay.
Yep.
Who wants to practice their sheets? Oh, wait, I was gonna say, I mean, we can still practice their sheets. After today, because we've been through the lecture of the sheets, at the beginning of our classes, we're gonna try and do one scenario, so you guys can see how scenarios are played out. So we'll just pull from the Cup of Doom, 2 people, and you guys can come up here and practice scenarios. This is all just learning, right? Right now is the time to learn. Nobody's gonna look at you and be like, you're stupid. That's not a thing. Like, we all miss things, we're all practicing, we're all learning. So, I can run through one of the medical sheets real quick so you guys can kind of see how the flow is supposed to go. So as you practice, we can do all that. Sound good? Or do you guys want to practice? It's up to y'all, but, I'm gonna step out. Chad's gonna give me or think of a scenario.
Should be a pregnant woman. Make him be a pregnant woman.
She's in labor. Alright. So what was that? Okay. I like it. What are you doing? Anybody called you?
Hey.
No? Yeah, there were sheep.
Hey, Chaz, before you get going, so while you're checking for like the head and everything, can you check for the back of the neck before you?
Yeah, so a lot of times according to the sheet, right? So if I'm coming down and I'm like checking Billy, right? So I'm gonna be in front of Billy. So if I'm coming down and I'm like checking Billy's head right here, when I get to right here and I'm checking his face, I can go ahead and look and just run my fingers down right here and then just kind of keep going, right? So your hand's already there, right there in his neck area, because you're checking his face, you're checking his jaw, right? Like all that stuff. And then you're looking for the JVD, tracheal deviation and all that stuff. So just run your hand behind it real quick.
Right.
Tap, tap, and keep it cooking. All right, so Billy said he wants to have rebound tenderness.
So you're having it coming out from top edge.
What?
When you're palpating, you're coming out of the down tenderness.
Mhm.
Okay.
Everything.
All right, we're ready. Okay, so you got paid out to a 25, see, I remember, 25-year-old male who's not feeling well.
Okay.
Go.
All right. How far am I?
So you're gonna be 10 minutes from your critical access hospital, and you're gonna be about 30 minutes from any high capable hospital.
By responding to a house.
You are responding to us.
Okay. BSI. My scene safe.
Your scene is,
Okay. I'm gonna do number of patients.
just this beautiful guy.
Okay. I'm gonna request additional ALS.
All right, your ALS is about 20 minutes out.
Okay. mechanism of injury or nature of illness.
Not feeling good.
He's not feeling good, so I'm gonna say it's a nature of illness call, because it's just a medical. I'm gonna consider C-spine.
Yeah.
Okay. Patient's injury, C-spine, Okay, so, my general impression of the patient, I'm gonna walk in.
So as you walk in, you find your patient right here. This is Mr. Billy. Mr. Billy looks pretty good. You see, holding on to himself right here.
Okay. I'm gonna check, assess his, responsiveness. So as I talk to him, hi, Mr. Billy, my name's Becca. I'm with the ambulance. What's going on today?
My side really hurts.
Okay, his side hurts, so he's alert, he's talking to me. That also tells me that his airway is patent. So his chief complaint is that his side hurts, right? So now I'm also gonna check for life threats. So this is where I would check for any major bleeding. Is he pooping blood? Do I see any major blood anywhere? No, okay, come on, look under your hand. Okay, perfect. So life threats, his airway's open. I'm gonna go to his airway, but as I do this, I'm gonna direct my partner to take a set of vital signs. I want a blood pressure, I want a pulse, I want an SpO2, I want a blood sugar, a temperature, and a respiration rate. I'm gonna feel his pulse as my partner is doing that. So your side hurts. Yeah, okay, all right. So now I'm checking his airway is patent. Does he look like
Thank
he's in shock at all? No, okay, is he having any trouble breathing? Yeah, I'm gonna,
I do have a trouble.
okay. I guess I'm gonna stand over here. So I'm gonna assess his breathing, so I'm gonna listen to his lung sounds while I'm here. What do I hear?
Lung sounds clear, equal power.
Lung sound equal clear, okay. I'm gonna check his circulation, so I already checked for his pulse.
Pulse is a little fast, but
A little fast, okay. It's like bounding, ready,
it's pretty bound.
it's bounding, okay. Skin color, temperature, condition.
A little warm, but other than that, it's pretty good, clean,
Okay,
dry.
pale, sweaty, you said dry. Okay, he's not showing any signs of shock at the moment. If he was, this is where I would treat for shock. So treating for shock, I'd lay him flat, I'd cover him with a blanket, give him some oxygen depending on his SpO2. What was his initial SpO2?
His initial SPF would be 98% of them there.
Okay, so he's oxygenating well. He's not having any breathing complaints. I would put oxygen on if he has had any breathing complaints at this time, or if he looked like he was struggling, or if his SpO2 was low. All right, so ABC, transport decision. As of right now, I feel like he is pretty stable. We're going to look a little bit further. What did my patient get for vitals? Sorry. What'd you get for vitals, patient?
135 over 72.
Okay.
Heart rate is 110.
Regular.
BGL is 118.
Okay.
And temp is 121.
What was his respiratory rate?
We'll go with 20.
And his SpO2 was 97, you said?
98.
Okay. Sorry, I'm a visual learner. Okay. All right, sir. So would you like to go to the hospital today?
Yeah, I think I
Okay.
should.
All right, so we're gonna get him loaded up, but as we're getting him loaded up, I'm gonna get a history. So I'm gonna start with my sample history. So your belly's hurting you. Is anything else going on?
No,
No.
just started like a pulsating drop in pain.
Okay. Are you allergic to anything?
No,
Okay. Are you on any medications?
no,
All right. What kind of past medical history do you have?
I don't know.
Don't know? Okay.
Never
When's the
been
last
to a
time you went to a doctor?
In
Okay.
like 20 years.
Oh, okay. All right. What was the last thing you had to eat?
Probably like a chocolate bar.
What time was that?
I don't know.
Okay. Have you been going to the bathroom regularly?
Yeah,
Okay. Any weird diarrhea, red poop, dark poop, nothing like that? Okay. And what were you doing when this started?
just sitting down watching TV.
Okay.
Started dropping pain.
Okay. All right. Now I'm going to go through my OPQRST. So again, when did this start?
About an hour ago.
Okay. Does anything make it better or worse?
No,
Okay. Can you describe your pain for me again?
just a throbbing pain.
Throbbing
Doesn't really go.
Okay. Lovely. Does it move anywhere else, or is it just right here in your belly?
It's just in my lower side.
Okay. If you were to give it a number on a scale of 1 to 10, 10 being the worst pain ever.
Probably an 8 or a 9.
Okay. And then, have you ever experienced anything like this before?
No.
Okay. All right. So as we're getting going, we got the vitals. This is where I would do we're loading them up on the ambulance. We're still keeping ALS coming. For interventions, I'm gonna keep monitoring them. I believe, as my field impression, that Mr. Billy here could be having a AAA, but I'm gonna do my assessment here. So I'm gonna do my skin assessment. I already did. I'm gonna do integumentary. Is it okay if I look at your belly? Okay. I'm gonna pull up, look at his belly. Do I see any discoloration? Okay, I'm gonna palpate your belly. I'm gonna start from the furthest point and work my way up. Any pain over here? It's this whole side here. Okay, because he described it as pulsating, I'm not gonna go. Oh, just throbbing. Okay, I'm gonna palpate. Do I feel anything? Do I feel anything here? Okay, no. Oh, down at the bottom. Okay. Does it hurt when I push in? When I release?
No.
Okay. All right, so he's got rebound tenderness in his right lower quadrant. He's got a slight fever going on. All right, I listened to pulmonary, so this is gonna be my second system. So listening to lungs, you said they were clear. Any trouble breathing? No. Okay. I already asked his ins and outs. He hasn't had any diarrhea, nothing like that. You notice you have a fever. Have you felt feverish?
No.
Okay. All right. We're going to go to like a cardiovascular. So sometimes heart attacks can present with abdominal pain, depending on the patient, what kind of history they have. So I'm going to go ahead and assess his pulse again. Still feels okay. I'm going to check I'm going to go ahead and obtain a 12 lead. I can't read it because I'm an EMT. I'm going to send it off to whoever it needs to be sent off for. All right. Let's see. So we got pulmonary, we got cardiovascular, integumentary, we looked at his skin, GI, we asked him about his belly, and then any kind of like vomiting or anything. No. Okay, very good. Let's see. Any kind of history of bleeding disorders, anything like that? Don't know about high blood pressure. Okay. And then I'm going to ask him, what other system can I assess here? I'm going to find one. Neurological, I guess. So he's talking to me, okay? Any weakness anywhere? No, okay, just your belly. All right, very good. So we got him on the stretcher. We're going to reassess vital signs every 15 minutes. My differentials, my biggest concern would be the AAA. After doing my further reassessment, I'm more leaning towards like appendicitis. Yeah, so it's not pulsing mass, or it's like more of like pain right lower with the fever. That would make sense.
I meant stabbing pain.
Stabbing pain. Gotcha. Okay. He said pulsating, and I was like, or what did you say?
It says pulsating.
He said pulsating. I was like, oh no. Okay. So we're reassessing every, well, right now he's stable, so every 15 minutes. Yeah, that's my field impression. No interventions at this time. I'm going to continue to monitor, watch for oxygen saturations with him running a fever. I'm also going to watch for vomiting. Having that, yeah. He's going to have a little emesis bag.
Okay.
Okay.
Would you like to give your patient report via radio?
Sure.
Okay.
BMGH, this is Rescue 7 for a radio report.
Rescue 7, this is BMGH super nurse.
Yes, super nurse. This is Becca, ambulance driver. So I'm en route to you with a 25-year-old male. Today he has a chief complaint of abdominal pain on the right lower quadrant. It is rebound tender. Right now I have my last set of vitals was 135/72. He's 98% on room air. His heart rate's 110. His respiratory rate is 20. His blood sugar was 118, and he did have a fever at 100.1 degrees Fahrenheit. I have no other interventions at this time. We'll be there in about 5 minutes. Do you have any questions? Coffee.
Yes.
All right. Questions. What did I miss on the sheet? Because I know I like bounced around.
A alert and where data comes from it.
No, that was our ASBO. She
Yeah.
said that when she walked in, he was alert.
I missed
Oh, yeah. I could have said that.
GCS.
Yeah, DCS of 15.
anything else.
Did you ask medications and allergies?
Yeah, so I did the sample. I asked SAMPLE, and then I did the OPQRST.
Anything
So
else?
when would you get the second round of
Depending on how stable my patient was, 15 minutes or
So
5.
it wasn't really good, but in the real world, you would have gotten a second round just in case.
So like our monitors are automatically set up to go off every 5 minutes.
Mhm.
So like when we turn them on, they just auto take vitals every 5 minutes.
Yeah.
So like for us, we're gonna just like automatically get them, but yeah. So like I said, I don't know, I think you talked about it, like you want a minimum of like 3 sets of vitals on any patient. So even if we're going from the little old people's condominiums over here to across the street, I get a set of vitals while we're in there, right? A set of vitals while we're like moving, and then another set of vitals when we get in the back of the truck, and then we drive over here, right? So,
Did I say that I was going to reassess every 15
Yeah.
minutes? I said that? Okay. I'm trying to go down the sheet like, what did I miss? Yeah, so just like that. That's all it's an open dialogue whenever we're doing these. Nobody's going to trash talk anybody. Nobody's judging you. We're all learning.
So if the patient's stable, and you said every 15 minutes, but the truck ride's 10,
Yeah. I'm going to
You just
do
do
one
it
probably
anyway?
every 5. Yeah.
so pretty much, depending on the time frame when you gotta go.
Yeah.
yeah, because realistically, when you're like in the real world, you're probably, unless you're like eating ski, right? Like you're probably gonna be inside somebody's house for 10 or 15 minutes at least. So like if you walk in and like get a set of vitals on them, like as soon as you make contact with them, by the time you get through talking to them and like doing all your stuff and like kind of going through that whole process and getting them out to the truck, it's probably gonna be about like 15 minutes, right? So then you take your second set. Then if you're 10 minutes from the hospital, like as you're like pulling into the ER, just pop a little button and let a set of vitals, because like your pulse ox is always on, right? So that's just gonna be a continuous monitor. As far as your blood pressure goes, all you gotta do is reach down and hit the little button and then let it run. And then, you know. So like when we were at Grady, we had to get manual blood pressures as our first one and last one. Where it was like, we did, according to our paperwork.
So why was that though?
That's a good one.
It's
It was
really
just one of those,
good.
somebody had control.
Yeah. Somebody messed something up.
Yeah, and manual blood pressures are, so like, here's my going, reason for manuals, right? So if I pop a blood pressure on you and your blood pressure comes back as something like ridiculous, right? So if I pop a blood pressure on you and the first one that pops up is like 250 over 120, and I'm like, listen, hit the button again, right? That's gonna be the first thing that I do is like, hit the button again, see what happens, right? If the second one pops up and it's still like 240 over 130, I'm gonna take a manual blood pressure, right? Because I'm gonna determine whether that's your real blood pressure or whether my machine's down. Now, if that's your real blood pressure, we got other issues. But that's what I'm gonna do. Same thing on the loading. If I check your blood pressure and like I get there and I'm like, and I pop a blood pressure on you and like I walk into Billy's house, like right now as he looks, and I pop a blood pressure and his blood pressure pops up to 70 over 30, right? I'm gonna check for that pulse, I'm gonna hit a blood pressure rate. If it pops up again like that, I'm gonna take a manual blood pressure, right? So like my going theory with manuals is if I can't find one, or if the monitor can't find one, because we have patients like, we had a patient one day that was bleeding real bad, and our monitor just physically would not get a manual blood pressure or an automatic blood pressure. So we were trying to do manuals, and even at a manual, the most we could get was like 60 over 1,000. Like that's how low her pressure was. So If you have something like really wild on the blood pressure scale, do a manual. If you can't get one with the automatic, do a manual. So they're definitely more accurate if you have good hearing. If you're like me and you're like half deaf, it might be better, it might be worse.
So this is why manual blood pressure is good. This is my spiel. What is this number right here? Map. Good. So mean arterial pressure. We want this to be greater than 65 or 70, depending on the textbook you read. I think y'all says, actually, I don't even know if your textbook mentions it, but I'm going to go into it. So whenever you take an automatic blood pressure on any kind of automatic blood pressure machine, this number is the most accurate. It gives you a random systolic and diastolic, but it's going to be very accurate for the map, right? So we're aiming for a good map. But here's the problem, is if I have somebody that's bleeding out, and I have had this patient, the same exact patient, and my monitor is telling me 110/70 and the map's 83, okay? If I take a manual and I get, let's say I get 105/92. Let me check what the map is on that. I cheat. Okay. So let's say I get this instead. This is what my monitor gave me, and this is what I get manually. They're kind of similar, right? Map's almost the same, like it's like 90, but how close are these numbers together? They're kind of far apart, right? 110 and 70. Now, how far apart are these?
Close.
They're close together, right? So this is something that an automatic blood pressure cuff won't give you. Whenever people start to bleed out or they have something like a cardiac tamponade, they get narrowing pulse pressures. So that top and bottom number will get really close together. Whereas this wouldn't tell me that. This just gives me a random systolic and diastolic, but the map's accurate. This is going to tell me about narrowing pulse pressures. So I've had a patient that was like, I'm puking blood. I never saw him puke blood, but I was like, whatever, your blood pressure's pretty decent. I got in, this dude was big sick, right? Doctor was like, hey, like this guy's, pretty sick. I'm like, okay. This is that, like, patients don't suddenly decomp, you just suddenly notice kind of thing. His pulse pressures were super close together, even in the manual blood pressure that I did take. And the doctor was like, you could have caught how sick he was because of how close these numbers were together. He was puking blood because he was volume depleted. But I wouldn't have even seen that. I didn't know what it was at the time, right? But now I know, like, okay, that manual blood pressure is important. So it can give you other clues, right? So yes, these are great when they're there, but it's important to at least get one manual whenever you're suspecting something. That makes sense. I know that's a lot of info all at once.
So look at your patient, look at the presentation, and go from there. Like the lady that we had that was bleeding out, that our monitor just physically would not grab a blood pressure on. Billy tried to get a blood pressure manually. Marcus tried to get a blood pressure manually. And Becca said, I think that I hear something around 60. Right? So like if you are looking at your patient and you're like, oh, they don't look good, and your monitor is like doing something stupid. Yeah. So use your resources.
Treat your patient, not your monitor.
And what's the first thing we do if a bad blood pressure pops up on your monitor?
Do
Hit
it
the button again.
So could you get a patient who's like, they don't need to go to the hospital?
I have a lot. If we have a patient that really doesn't
Yes. Yeah, I mean, I don't have to pay for the ride. They're like, I hurt my foot. And I'm like, yep, I've done it. They're like, yeah, I need the ER. I get paid the same whether I take your blood to the hospital or not. Let's go. I've been no way in lines. Yeah, you get, and that's not really like your determination, right? Like, we've had patients that are like, we've had those patients that are like sick, but they're not like ER sick. Like, cool. You want to go to the ER? It might make you feel better. Like, that's between you and your financial. Hop on in, you just take it.
The amount of like kids that we took in Atlanta that like just had a fever.
Yeah.
Okay.
Yeah. Amount of freaking 30-year-old grown men.
Yeah.
I don't know what it is, freaking 30-year-old grown man call me, like, tum-tum. Your tum-tum ain't never heard before, bro? Like, why you Taco Bell?
Her transfer.
Cool, man. Let's go to the hospital. Oh, okay.
That's not really what I start.
Cool.
See my work. That looks like a nice.
So, 8:30, who all's going tomorrow?